Today on Raw Minds, I have a guest who is not just in medicine, he is helping change medicine. Dr. Eliot Siegel is one of the pioneers who have helped move radiology into the digital age. Back in the 90s, he helped lead the first radiology department in the United States. That means before hospitals were even working on the way that they do today with digital scans, digital imaging, and faster access to medical pictures. Dr. Siegel was already helping build the future. He is a professor, researcher, radiologist, nuclear medicine leader, AI thinker, and one of the founding physicians at United Theranostics. I think I said that right. And today we are not just talking about medicine, scans, cancer treatments, or AI. We are talking more about people because behind every scene is a human being. Behind every diagnosis is a family. Behind every new treatment, someone is fighting for the time, more hope, and more life. Dr. Siegel has spent his career at the edge of medicine, helping bring technology, AI, digital imaging, and cancer care together in the way that can change lives. This conversation matters because men are bad at waiting until something is wrong before they speak up. We ignore signs, we push pain down, we act tough, and sometimes that silence costs us. So today we are going deep. We are talking about cancer, fear, men's health, early detection, AI in medicine, radio. I can't even say that word, but therapy, but you'll help me say it when you come back on, and what the future of care could really look like. And before we get into it, make sure that you like the episode, drop a comment, share it with someone who needs to hear it, and follow Raw Minds. This is how we build for the people fighting battles, but nobody wants to hear. And looks like someone is doing their yard outside. But anyways, I just want to say, Eliot, thank you for coming on. I don't know if, they're right. Can you hear them? They're doing their
Little bit,
lawn.
just
Yeah,
barely.
right at my window here, of course, at this time. Anyways, if you could please, I like to get all my guests to shoot out where we can find you, your links, and maybe your website that we talked about, if we can.
Yeah, thanks. I really appreciate it. So, founder of a national entity that is called United Theranostics. And so here's our website, unitedtheranostics.com, UNITEDTHERANOSTICS.com. And those of you who kind of hear Theranostics may think of Theranos and think of Elizabeth Holmes and the issues related to Elizabeth Holmes and Theranos. But actually, Theranostics is a new and emerging field in medicine and in oncology. And it really represents a combination of of therapy plus diagnostics. So it's Theranostics. And it really refers to the fact that we are able to personalize treatment for patients by imaging the patients, and I'm a radiologist, and also treating the patients. And so I do nuclear oncology, and then treating what we see and seeing what we treat. And so as we treat the patients, we can see how the patient's tumors are changing with the treatment, and then we can tailor the next treatment based on what we see. And then after that, we can look again and keep looking. So it's the ultimate in personalized and precision medicine for treating patients with a limited subset of cancers now. It's prostate cancer and neuroendocrine tumors. But as time goes on, virtually every type of cancer is now being investigated for this brand new type of therapy.
That's insane. I really want to go into other stuff, but right now, can you explain like really what the imaging is, like the AI imaging of that, like so people can
Sure.
understand?
Yeah. So the AI imaging utilizes PET scanners and SPECT scanners. So one of the fantasies that people have had for many years is the idea of finding a magic bullet for cancer. And everybody who has cancer is scared, and it can be really incredibly devastating news. When somebody goes to meet with their doctor, whether it's their oncologist, their urologist, their surgeon, what they want is to ask the question, what can you do to treat my cancer, but not make me sick as
Mhm.
part of doing that? What can you do to not hurt me while you're treating the cancer? What can you do that would be personalized to me? I don't want you to just read the textbooks or read the journals. I want you to know everything possible that you can know about me and create a tailored therapy just for me and my particular type of cancer. And so if you can imagine, I don't know if if you've ever seen the movie Fantastic Voyage, where they take a submarine and they miniaturize it and they inject it
No.
to a patient, and the submarine, this little nano submarine, then goes to find what's wrong with the patient and then zap it essentially. And so the idea of being able to engineer these nano molecules where billions of dollars are being invested in finding the specific molecule that is able to find a particular type of cancer. So we've already got FDA clearance for the nanoparticle that's able to find the vast majority of prostate cancer cells and
Wow.
another type of cancer called neuroendocrine. But patients who have pancreatic cancer, lung cancer, breast cancer, all sorts of others, there are already drugs that are in the pipeline with these nanoparticles that are able to find individual cancer cells and be programmed then to kill those cells with a radiation particle. And so the
Nice.
imaging that we do is able to image these nanoparticles so that if a patient has prostate cancer and it has spread to their lymph nodes or spread to their bones or to their lungs or to their liver, we're able to image the individual cells that are essentially taking up these
That's
nanoparticles
crazy.
and create a map of where the cancer is in the body. Once we can create that map, and we use PET scanning. So stands for positron emission tomography. So it's antimatter essentially that we end up injecting. That's the P, the positron in PET scanning. And we're able to create an image of the body, but not an image like you would get with a CT scan or an MRI scanner or ultrasound system, but actually image the cancer directly, because each one of the cancer cells is taking up this
Yeah.
small amount of radiation when we do diagnosis. And then when we treat, we do the same nanoparticles, but we are now delivering a lethal dose to the cancer cells.
Took
And
it.
so that's pretty much how it works. So now there's a scramble in pharma among many companies throughout the world to take individual types of cancers and be able to design these nanoparticles that we can attach a radioactive particle and a beta particle, an
Mhm.
alpha particle to, or a gamma particle, to be able to see the tumors and then treat the tumors. And so it's an emerging field. And I think in the next few years, you'll
That's
see it treating a
crazy.
large number of cancers. And so it's really satisfying to be able to sit with a patient. Here's an image of all the cancer cells in your body. Here's our strategy. And what we're going to do is we're going to give you a therapy that is going to then take the delivery mechanism that finds the cells in the first place and now deliver this dose of radiation to kill each one of those individual cells. And
That's
that's
wild.
really, when we talk about diagnosis and therapy, we're talking about therapy plus diagnostics is theranostics. And so we named our company after the specialty of theranostics.
I love it. I think that's crazy. So like, so pretty much, I guess you could say in so God, of course, when I talk, this guy comes by my window here. He's like, literally, sorry about this, guys, but it's almost like it's like Google Maps for your body to find the cancer, and is that how it works, like that?
Yeah. So if you think of Google Maps, then we're able to essentially create a map, but just of the cells that are the cancer cells. And in addition to those, we're able to image certain organs of the body that clear the cells. So when we essentially inject our radiopharmaceutical that finds the cells, that radiopharmaceutical is cleared through the body, through the liver and through the kidneys. So we can see some of the organs of the body as the radiopharmaceutical is clearing through it. But what's really amazing is that when we do the PET scan, and these are PET CT scanners, so it's a PET scanner that is connected to a CT scanner. So we can get the CAT scan images that you might be used to looking at when you look at
Mhm.
CAT scans or MRI scans. And on top of that, in color, we're able to project the cancer cells. And so you're able to see, as you're looking at the CAT scan or the MRI scan, throughout the body, you're able to see where the cancer cells are.
Where they are, yeah.
So the equipment that we use in our centers are PET CT scanners and another nuclear medicine type of camera after we treat the patient, and we watch the radioactivity clear from the body to know how much of a dose that the tumor cells got and how much of a dose other parts of the body incidentally got. We use something called SPECT, which is another type of nuclear medicine camera. So these antimatter imaging PET CT scanners are able to combine the best of the anatomic detail we get from a CAT scanner with the functional detail we get with the map of the cancer cell. So it's kind of like a Google Maps where you can
Hmm.
have, let's say, certain features projected on the Google Maps. You have the background of the map, which is like the CT scanner that shows the body. And then on
Hmm.
top of your Google Maps, then let's say you project the traffic, for example. So now you know where all the cars are projected on top of the map. So the PET scan gives you the cars on top of the Google map. Only in our case, we're looking at tumor cells
Tumor cells.
rather than cars on top of a map.
That's insane. That is, like, wild. And how new is this technology? Because, like, honestly, this is the first I mean, I've seen in videos, like, you've seen in movies and stuff where, like, the nanos go in and they do
Yeah.
all these things, or, like, Iron Man's his whole suit is nanos, right, and stuff
Yes.
like that. So I've seen all that, but, like, this is really the first time I've really, like, heard anything like this. Like, how really new is this to the market?
Yeah, so it's been around in Europe for quite a while, but it's taken the US because the US tends to move a bit more slowly,
And
arguably.
Canada here. I'm in Canada, so us too.
Uh,
So we're the same, yeah. Even
yeah,
slower over here.
yeah. And I think Australia and Europe are leading the way, but the FDA only approved this just a few years ago, around just before the time of the pandemic. So it's been
Okay.
maybe 6 years, 7 years or so. If you look at neuroendocrine cancers and then even a little bit more recent for prostate cancer. So there's a pipeline of about 150 of these different types of molecular therapies that are radioactive waiting in the wings. And there are clinical trials that are taking place right now. United Theranostics is doing 21 clinical trials right now on all sorts
Oh,
of different
wow.
types of cancers. But from a clinical perspective, if you're asking what's available and FDA cleared today in the US, these have been around for 5, 6, 7 years or so. And it's for prostate cancer and for neuroendocrine tumors. But prostate cancer is incredibly prevalent. I mean,
Definitely.
if you look at 64-year-old patients, 46% of 64-year-olds and older have prostate cancer and just don't know it. And that's a major challenge and dilemma. As you get up into the 70s and 80s, that number increases precipitously. And the really interesting thing about prostate cancer is the vast majority of people who have prostate cancer never know,
Mhm.
never find out they had prostate
Yeah.
cancer. They die of something else. And most prostate cancer is relatively benign, not aggressive, stays in the prostate, doesn't create issues for patients. But a certain subset of prostate cancers are aggressive, metastasize, and cause all sorts of morbidity and mortality in
Mhm.
patients. And so, one of the interesting thing that's happening is trying to tailor these new nanomolecules for particular types of cancers, and even the potential to take a particular specific patient and design something for that particular patient that is optimized for their cancer. One of the challenges is that as cancer spreads, it's not just the same cells that cause the original cancer, but they mutate. And so the
Mm.
challenge we have as oncologists or nuclear oncologists is whatever treatment worked for the original cancer cells, let's say in the prostate, they may be different and may have changed as they
Mhm.
go to different areas. And so it turns out that even with mutations, there really are not any cells that are able to resist the damage that is done by these alpha and beta particles of radiation. So it turns out that it's an incredibly exciting, innovative field. And I think everyone's going to be learning more and more about it. You mentioned that, you didn't really haven't heard a lot about it.
Mhm.
Most patients have not ever heard of it.
Mhm.
And many oncologists and urologists are just starting to learn about it. So, really appreciate the opportunity to talk with you about it and
Mhm.
educate all of the folks who listen to your show about this as a possibility.
Yeah, this is amazing. Like, you have no idea. I'm getting crazy goosebumps. Like, it's just nonstop goosebumps, goosebumps. Because I think this is wild. I mean, my mom's got lung cancer. I know, but I mean, so like cancer runs in my family. My dad's, I don't talk to him anymore, but last time I know he had lymph node cancer as well.
Lymphoma, yeah,
Yeah,
that's a type of
lymphoma.
blood cancer.
Yeah, and he had like this, it was the size of, like, baseball almost, like,
Hmm,
on this, up by his neck here. It was
yeah,
crazy, yeah.
a really common location for lymph nodes above the clavicles. They're called
Yeah.
clavicular lymph nodes. And, we've advanced tremendously in our understanding of cancer and treatment of cancer. There are still some cancers that, are very resistant to therapy, but it's
Mhm.
incredibly exciting the advances that we're seeing in cancer care. And Theranostics has been a really exciting pivot for me because since the field is so new, practically
Mhm.
everybody in the field is relatively new to the field also. And so my career has been more as a diagnostic radiologist and interventional radiologist doing interventional radiology procedures, doing MRI scans, ultrasound, CAT scans. And then I did more and more nuclear medicine and became a nuclear medicine specialist. And now I'm subspecializing in nuclear medicine in the treatment
Sure.
of
Mhm.
patients with these diseases. Many
And
people,
AI too. You're learning AI too. That's a whole different ball game
yeah.
too,
So I'm
you know what I
also a
mean?
professor of computer science at
Yeah.
University of Maryland and run a national course on AI applications in medicine. And that's another really fascinating area, how AI is changing the way that we
Mhm.
practice medicine. It was really fun to chat with you a little bit to hear
Yeah, we
about
can talk about it too. I mean, if you
amazing
want
things
even
that
we
you're
can, yeah.
doing with AI and interfacing with, quite a variety of folks who are getting help with mental health issues and addiction and other issues. But as an oncologist, what I'm faced with as I'm talking with patients is just this incredible deluge, mountain of data. So now I've
Mhm.
got access to all of these images from PET scans and MRI scans and laboratory studies that are being done, genomic data, DNA data. I've got DNA data on the tumors on all of my patients. The problem is that there's no human that can process all of that
Mhm.
information and keep up to date on what's new. And so being able to take advantage of the latest developments in AI to
Mhm.
essentially work with the AI as an assistant where it's able to read all the latest literature. It's able to digest hundreds of pages of lab reports and prior procedures in patients and genomic data and dosimetry data after we treat the patients to see how much dose they got and how can we keep the patients as safe as possible. And then being able to make recommendations for the patients that I, as the oncologist, now are able to review and add my own experience, my own perspective, and working hand in hand allows me to provide much more effective and much safer care in a similar manner to the way that you're taking care of all of these people with what you're doing with AI. It's been fascinating for me to bring my interest in AI and then tie
Mhm.
it to medical care. You may remember the IBM Jeopardy match between Jennings and Rudder, where IBM back in 2011 created software that would play against the two best Jeopardy players of all time, Jennings.
Okay, yeah, yeah, yeah.
And so I actually had the privilege of being on that IBM team as their medical consultant. In
Really?
2011, after they soundly beat Jennings and Rudder at Jeopardy, um, the news channels just exploded, newspapers and interviews. Everybody wanted to know, like, what's the next thing that you're going
Mhm.
to do? And they said, oh, we're going to work with Dr. Siegel to bring AI to medicine and healthcare. And that was kind of a major introduction to AI. I think IBM kind of dropped the ball a little bit as far as taking advantage of all the cool things that they had done with that version. But there was a
Mhm.
renaissance then, a few years later with the large language models and convolutional
Mhm.
neural networks. And so, what's happened now is all of a sudden now AI is not just accessible to, the experts at IBM, but it's at the fingertips of everybody. And I'm finding my patients who are coming to me have already interacted with their own versions
Oh,
of
wow.
AI. They're asking really good
Mm,
questions. They're
mm,
making suggestions, and in many cases, they're helping me look at new
mm.
avenues and new possibilities. So it's been really exciting, as I think you implied, being able to take my interest and background in computer applications and artificial intelligence and combine them with oncology and then combine it with the diagnostic imaging, the Google Maps that you talked about.
Yeah, it's wild, like, everything's like and it fits, like, it's starting to fit nicely, you know what I mean? I don't understand why every time I gotta talk, this guy's gotta come by my window here, but I don't get it, but
Yeah,
it is what it is.
I can't hear him, and hopefully
Okay,
other.
it's really loud. He's got a blower, and it's like literally right at my window. I'm in ground level here, so
Yeah, I think
but
your mic did a good job of rejecting the background.
it better. This is an expensive mic. But
Right.
yeah, I mean, like it's just it's amazing, and like that's what I was thinking. Like I was while you were talking because. I've talked about the legacy method here a couple times. It's not
Yes.
fully done, but and that's what it is. It helps rebuild. It's personalized. No two like you could take the exact same onboarding, the exact same questions,
Mm,
but it will be totally different. No two people will have and that's the same as what you guys are doing, right? No two people. It's
yeah.
going to be different. I mean, you'll have like almost the same cancers and stuff like that. You know what I mean? But like the
Yeah, but the
direction and
same
everything.
cancer is different
Yeah.
in 2 different patients who have different renal function, different immune systems, different lifestyles,
Hmm.
different risk factors, different genetics themselves, and so, you know, it really is possible now where it never has been in the history of medicine to be
Hmm.
able to combine all of these factors that are specific to a particular patient and be able to then make decisions for that patient and to
Hmm.
tell a patient, well, you know, there's 3 chemotherapies and we're going to try the first one A and then B and then C. We're going to try A because most patients in the medical literature respond to A, but some respond to B and C. You know, C is curative, but only 17% of patients respond to C. So we're going to start you with A. But what if you could use all the information that was available on the patient and
Hmm.
immediately recognize that they are a C and that they're going to respond and they're one of those 17%? Then you go directly to that treatment where you can treat them early before they end up getting into trouble. So if with all the different treatments that we have available, if we can personalize the
Hmm.
treatment plan to everything about the patient and not worry about the complexity because AI is able to help us sort all of that out and then let humans make the final decision about
Hmm.
what to do. And being able to have that available every time I see every patient now is really a major game changer. And it's very much consistent with the way I think medicine is going.
It's almost like you have like another doctor on hand, that's your right hand man, the person that you talk to deliver, you know what I mean? Like for me, when I use AI, I'm telling you, I use it for everything in my life. Like even when I was in the hospital with my mom, and I didn't understand her charts. So all I did took chat GPT and I paid for the
Yeah.
extra and I just boom, 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 boom. And it told me everything,
Yeah.
and it told me everything.
Most of my career, I've been at the University of Maryland, at the University of Maryland School of Medicine and the Department of Radiology. I also was responsible for the veterans in West Virginia and Washington, D.C., and Maryland for radiology and nuclear medicine.
Mhm,
And so a lot of my career, I've worked with medical students and with interns and residents and fellows and trainees. And so in many cases, they've had the ability beyond what I can to spend time looking into the patient's history, looking into the chart,
mhm.
and then discussing the patients with me. And then we can discuss it with other physicians. And so, in many ways, I still, as the person with the medical students and the trainees and others, ended up having to make the final decision about what to do with
Mhm.
the patient. Sometimes the medical students would come up with brilliant ideas that would be really helpful. Sometimes they would come up with just things that wouldn't make any sense or, what you
Yeah.
might say with AI hallucinations. And so
Mhm.
what I found is that the AI is not substituting, but it's acting much more like my trainees that
Mhm.
have the time to be able to go out, gather all this information, organize it, present it to me, and then I'm able to end up taking that, making decisions about them. And so
Well,
that's
I
where
hate this.
hope will stay rather than being replaced by the AI. I really think humans in the loop are going to be required for quite a long time.
Well, and I think, like, even, like, it's the agents now are the ones that
Yeah.
are like, that's what runs my program are all agents, right?
Yes.
And, like, I've developed my agents where they grow, so they'll learn from you, and they teach themselves
Yeah.
something I didn't even tell you, but, also they score themselves. So I made sure that they score themselves. So they
Yeah.
have to be at a certain score, right? To be learning and feeling. So they
Yeah.
actually score themselves and they judge each other on their score to make them accountable. It's crazy, right? With these agents. So
Yeah, well,
they're like
it's
that.
interesting that you find that. I run a national meeting in AI in medical imaging, and a lot of the literature and the abstracts that are being presented at the national meetings, including the one that I run, are on the value of these agents. And people are increasingly finding that rather than one large frontier model like
Hmm.
ChatGPT, what one can do is break up multiple different tasks, and you can have agents that judge other agents. And so you
Yep.
have auditing agents, and you have agents that come up with ideas, and you've got agents that communicate with each other.
This is
And
crazy, man.
yeah,
Sorry. I'm sorry. I'm just blown away because I'm just this guy that has a podcast for all minds. You know what I mean? That wanted to help people and built this legacy method and built these agents. And I didn't know. And I have that. I like I told you, I have that structure already. I
right.
have the architect. You know what I mean? I have each
Yes.
agent feeding each one. Right. The architect is the brain of it all. So
Yeah.
you're not just talking to one agent because then you're filling, it's just overloading, 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 right? And
Yeah.
how I want it, like I specialize. So that agent is specialized in that. That one's specialized in that, and so on. And I
Yeah.
built that, and it's just what you're saying is just like, wow, okay, I'm doing something right here. You're
No,
you're
you
just
are. And
proving it.
the
Yeah.
overall trend, I think, in AI is for more and more specialty models that are coming out. So these large language models are having special features. So for example,
Hmm.
Claude has evolved to become the coding favorite. But there are medical applications such as MedGemma, which specializes specifically in medicine and specifically in understanding and parsing information out. And
Hmm.
so every day there are new models that end up coming out that
Hmm.
specialize and are specially either fine-tuned or trained in a variety of different aspects and subspecialty areas. So
Yeah.
for me doing nuclear oncology, having the knowledge that I might have if I were consulting a pharmacist or if I were
Hmm.
consulting a subspecialist surgeon, and being able to then have the equivalent of what we might call in the hospital a tumor board with multiple personas that are able to weigh in on a particular patient's care. It's really fascinating to be able to do that. And it's been a great learning experience. So
Hmm.
this whole idea of United Theranostics has been one, personalized and precision medicine, see it and treat it. The other thing is bringing this type of therapy to everybody's local neighborhood. So,
Hmm.
because so many patients with prostate cancer, for example, or neuroendocrine or other tumors find it really difficult to take the trip over to Mass General or to Memorial Sloan Kettering or UCSF or wherever you end up living, it can be extremely difficult for these patients that are already fatigued, they're already sick, being able to have access in suburban areas and bringing the access of being able to do these infusion, super high tech therapies to all sorts of areas within the US. One of our centers is in Las Cruces, New Mexico, a place where
Okay.
you would never think would be one of the early high tech
Hmm.
adapters. But the patients there are really, really very appreciative of being able to have access. And many of them would not be able to have treatment if it were not for a center that was close to them that could do the diagnosis and being able to do the therapy also. So the third major pillar that we have is accessibility.
That's beautiful. And that's the main thing too. Like you said, that being said, is it like can it be done like at someone's house as well, or does it have to be in a hospital setting? Like,
It has to be in a clinical setting. Our treatments, I've left University of Maryland in my role as vice chair there. I've left the VA, although I'm still doing some remote work for them. But the reason I left was because I couldn't have a conflict of interest where I had this private practice, United Theranostics, that would be competing, with those. There
mhm,
would be conflict of interest, especially since I was at the VA in charge of the department. One of the conclusions we've come to is that hospitals are increasingly going to be doing this type of theranostics um, care for patients. But what's really needed is it in an outpatient environment. And so 70%
mhm,
of all the cancer care that is not done in the hospital setting. It's done for patients on an outpatient basis. And so having these facilities that are not hospitals, but that are clinics that
Mhm.
have something called a hot lab within the facility where we keep the radioactive materials safe and lined with lead walls, for example, and where we have the specialty technologists that understand how to handle these, how to work with the physicians to do the infusions, where we have the ability to house these PET scanners and SPEC scanners. And so it doesn't have to be in a hospital environment. And that's really our major premise is we want it to be a place where you could just drive to as though
Mhm.
you were just driving to the mall or driving to go someplace shopping, be able to have easy parking, just walk right in. Everybody kind of knows your name because we see you over a course of 36 weeks or so for
Mhm.
treatment for prostate cancer, for example. And being able to have sort of a warm, supportive
Mhm.
environment where you bypass the hospital, which can seem, just
It's
ironically like a
scary.
very,
S
that's right.
Yeah,
You're already
scary.
scared. And now you've got to figure out how to park at the hospital. You've got to figure out where to go. They tell you this part of the hospital is where you have to go find your imaging, and this is where you want to go to
Mhm.
get your labs done. Having all of that in one compact outpatient facility is really what we've been setting up. And so
With
looking
easy
at it,
parking.
say again?
With easy parking, right? Because the
With easy
hospital
park
sucks. Yeah.
and parking, if you talk with the patients, I mean, they don't care that, Dr. Siegel was professor and has written, a bajillion articles and, where he graduated in his medical school class. They want to know about parking. They
Mhm.
want to know about whether or not they're going to be seen and heard as people. They're going to want to know whether or not someone's going to take the time to be able to listen to them and to personalize the therapy for them. Even having our front desk and being able to greet the patients as they come
Mhm.
in and get to know the patients. We get to know the patient's grandkids and family. And, I think
Yeah.
that's difficult to do in a hospital environment.
Well, just to stop you there, it's like in the hospital. I mean, I've been in the hospital so many times because my mom, right? She's
Mhm,
in her 82, lots of trips. And
mhm.
it's difficult, you know what I mean? Like, you see usually you have what, 1 doctor, maybe 2 doctors running around in that little section, and how many patients, you know what I
Yeah,
mean? And how long are you gonna have that one-on-one? It's usually you see a nurse, and then another nurse will come, and then that same nurse will come again, and
yeah,
another one, and then you see the doctor for, like, what,
yes,
10 minutes, and then he
yes,
disappears,
yes.
you know? And it's scary, like, because I'm gonna say this straight up, like, you got cancer, as soon as someone thinks cancer, I'm dying, a lot of people, as soon as you think that, is death, right?
Yeah.
But
Well, I think the other
Mhm,
challenge also is the fragmentation of care. It's like, well, oh, you've got a problem with your heart, grandpa. Well,
mhm,
we've got to send you over to the cardiologist. Or, oh, it looks like, you're having some incontinence or you're having
mhm,
erectile dysfunction or whatever the issues are. We're going to send you someplace else. And then you end up bouncing around. And, the philosophy of having kind of the advantages of sort of a primary care
mhm.
local physician, but having access to this high tech technology for diagnosis and therapy is really the theme of what we've set up.
Yeah. Yeah, I think it's great. I think it's warm, like you said, it's warm, like, you really wanna cater to these people that are coming because, they have cancer, they're going through these things, they're scared, their family, there's so much going through. And,
Yes.
it's very important like that to have that warm, the comfy, acknowledge the person when they come into the room, make sure they're okay and stuff. I mean, like, as much as a hospital wants to do that, it's hard. At the end of the day, it is hard. And,
Yes.
it really is, but like that, a smaller, small, like you have, and you have everything there. I
Yes.
think, I think you're winning. You're winning for that, brother. I really do. I
Yeah,
think
well,
that
thanks.
what you're
It's
doing.
been really exciting as the number of centers have grown and as we're seeing more and more patients. And one of the advantages as we get larger is that we keep all of the records of our patients. And so you were talking about AI and the
Mhm.
capability, any one doctor, such as myself, can anecdotally remember some of the patients or many or most of the patients that we've seen. But if you've got dozens of doctors who are all seeing patients, making decisions, and then recording what the impact is of their decisions. Now you're building up a database, a knowledge center within
Mhm.
a large network that maybe any one hospital or any one facility wouldn't be able to. And so being able to tap our own experience with patients. And when a new patient comes in, have we in our practice seen a patient like grandpa who's sitting in front of me with a very similar set of presenting issues with very similar genomic characteristics, with very similar, stage of cancer. And can we learn from other people that we've experienced across the country and be able to apply that specifically to that patient? So as time goes on, and as you mentioned, Theranostics is pretty recent.
Hmm.
As time goes on, we have more and more data that we can use on our own to be able to treat the patients. We also do clinical trials. At any one point, we're doing 21, right now, 21 clinical trials on brand new therapies for types of cancers that are now just being investigated with these nanoparticles and the molecular therapy. So, we are learning formally in the clinical trials in a very prescribed way, but also in routine clinical care. Every patient we see becomes now an additional part of our database. So, without, while we can keep the patient's information private and secure, we can have the AI go back and look through and help us make decisions about new patients based on the aggregate experience of all the
Wow.
doctors that we have.
Yeah, that's incredible. I mean, the future is just so exciting. You know what I mean? For all these things that are coming, like from what you told me, I'm not a doctor, I'm not in, but I'm excited for you because like it's just so exciting. And like if you know about AI and you're using AI, and every day is just getting crazier and crazier,
Yes.
and it's just exciting. Every day is a new excitement, new breakthrough,
Yes.
new thing. So I'm very excited for you guys. I think it's amazing what you're doing. I do
Y-
have one question though
Yeah.
for all the men out there.
Also, just to follow up,
Yeah,
if
yeah.
I may, and that is one thing that really excites me is as patients are essentially learning more, patients are becoming advocates for themselves. So,
Mhm.
many years ago, there was this TV show, Marcus Welby. And, Marcus was this family doctor that would come to the patients' houses and he knew all the patients and knew absolutely everybody. But, what would happen in that era is whatever Dr. Welby said, the patient said, listen, you know best. And
Mhm.
patients took a relatively more passive role. And now what we're seeing to a greater extent is patients are becoming their own advocates. Patients
Mhm.
are learning about their disease, patients know about themselves. And so they're coming to me asking, better questions. When we're treating them, they become a partner in the care rather than just a passive recipient of whatever medications or instructions I'm giving them. And so that partnership with the patient becomes much more effective and safe than in patients who are coming to me as, the
Mhm.
person telling them exactly what to do and how to do it. And so that partnership, I think, is something I'm seeing more often. And AI may be accelerating some of that also. Sorry, you had a question. I'm
No,
sorry.
it's okay, and it probably even sometimes will blow you away, right? Where the
Yeah.
questions that they come and stuff like that,
Oh, and there are
right?
patients who come to me saying they just read about this new treatment that, maybe in Mexico or in the Philippines or someplace, where they're trying something experimental and, they want me to comment on it. And so in many cases I've read about it or know about it, but in some cases I need to go and read
Do your
and learn
research.
myself.
Yeah.
So the patients do very frequently end up educating me, not only in stuff that they know and they've read, but as
Mhm.
we're treating patients, I'm learning new things all the time.
Mhm.
And that's what for me, makes medicine exciting. So the things that excite you about what we're talking about excite me about it and want me to learn
Yeah.
more too.
That's beautiful, man. I honestly, I'm very proud of you guys and your whole company and just the whole medical industry too, and what you guys are doing. I do want to say this though, because this is a men's mental health podcast, and probably a lot of the men were wondering. So, because of this new technology, do they need to bend over and get that prostate exam now?
Well, think that the art of a really good physical exam is waning a little bit. And I think now people are doing all sorts of alternatives to look for prostate cancer. So the paradigm of seeing your doctor and having them put the glove on and feel your prostate, I think that works when the prostate cancer is larger and the nodules are larger. And
Hmm.
there are certainly folks who do a huge number of those and their hands are, more increasingly sensitive. But lab studies such as a PSA study are much more sensitive to early detection of prostate cancer. And you have to be careful with the PSAs because more common than cancer is prostatitis, inflammation of the prostate. And
Okay.
so you can have an elevated PSA level associated with inflammation of the prostate and with cancer also. So what's important is to get these lab studies and to have essentially a trend to see what's happening over time. So, if you
Mhm.
have a high value one time, and then you end up coming back and having it checked again and it goes down, it was probably inflammation. If you have one that's continuing to rise, it's less likely to be that. And we have the ability to image the prostate directly with MRI scanning, and the PET scanning that we were talking about allows you to image the prostate also. But for people, especially with a family history of prostate cancer or concerns about prostate cancer, I think the starting test is PSA. You may
Okay.
remember former President Biden, who was diagnosed with fairly advanced
Mhm.
prostate cancer, very famously quite a few months ago. One of the things that his doctors were criticized about is the fact that they had suggested that after a certain age, there really probably is not a need to continue doing the screening because these patients are probably
Oh,
at an
wow.
age where they would probably die of something else. And so, even with the best medical care in the world, his doctors were not screening him for prostate cancer.
Mhm.
And I think that's why by the time it was discovered, it was advanced and it had spread outside of his prostate to other areas of his body.
Mhm.
And so I do think that it's important to have the physical examination. I think there is value in the rectal exam, but we have tests that are so much more sensitive nowadays to prostate cancer, and the lab
Mhm.
study is becoming a routine part. When you go in and you get your lab studies done as a male, past a certain age, maybe it's 45, 50, it may vary, then you end up getting results back. And if your PSA is higher than a certain value, then people will end up having you back, get another lab
Mhm.
study, start working you up for the possibility of cancer. And then if there's a high suspicion, then you can get a transrectal biopsy of your prostate that is guided by MRI and ultrasound or done without the guidance. And then that specimen is sent to the,
Okay. So for everybody listening, it's still important to follow up and
yeah,
do
the rectal
sorry.
exam, and to see your practitioner and to, I think those rectal exams are still a major part of
Okay.
the physical exam process. And even though they're not the most sensitive study, they really provide a good deal of information still.
Yeah. And that's why we're still doing them at the end of the
Yes.
day. That's why we're still doing
Yes.
them. I do wanna ask too, is this only based on cancer though, like these nanos and stuff, like, or are they gonna be involved? Do you think you guys are gonna be evolving to like other stuff to like, attack other stuff to help in the
Yeah,
medical
that's a
field?
fantastic question. So we talked a little bit, you mentioned Google Maps, and
Mhm.
we talked a little bit about PET scanning. And so, PET scanning, in addition to finding cancer cells in a variety of different ways by either using molecules that are programmed to the cells, or we have a type of PET scan that is the most common type called FDG that looks at utilization of glucose, sugar utilization. It turns out that if you have cancer, then the cancer itself is utilizing and metabolizing sugar at a much higher rate than your normal healthy cells. So, being able to get this FDG scan essentially allows one to screen for a very wide variety of different types of cancers. And so we can end up imaging many types of cancers. But PET scanning also is being used in many other areas. For example, Alzheimer's disease. We now
Mhm.
have a treatment for Alzheimer's disease that people are increasingly now, especially for
Really?
patients with early Alzheimer's
My
disease.
mom has that. That's why
Yeah.
I'm very yeah, my mom has she had dementia, and it actually went from dementia into Alzheimer's, so, like, I
Ah,
guess it moved over into that, and it was bad, like, it was really bad to the point, like, she was opening up drawers and pouring juice in there. She
yes.
went up to my sister and said she forgot how to open up a door. She couldn't get out of her own bedroom,
Yes.
but now she's on some pills,
Yes.
and she is, like I mean, you wouldn't even think that she has it.
Wow, that's amazing.
Yeah.
That is an amazing recovery. So there are many types of dementias, but the most common type of dementia is Alzheimer's disease. And
Mhm.
so we now have the ability not only to treat it, but also to diagnose it. So there are PET radiopharmaceuticals, these nanomolecules that I was talking about, that look for the amyloid deposition or tau deposition in the brain. So I can take a patient and scan them and determine how much amyloid there is in their brain, and then correlate that with the likelihood that they have Alzheimer's disease or the stage of Alzheimer's disease. And so that's been a really major game
Wow.
changer. And the potential to be able to do that to monitor therapy is important. We talk about amyloidosis. A lot of patients that have significant heart failure and significant heart disease have amyloid deposition in their heart. We have the ability to be able to image that. For myocardial ischemia, we can use PET scanning to look at patients with coronary artery disease or find patients that are at risk of a heart attack. We have the capability of being able to find infections in patients and to find what the source is. A PET scan can be done, and infections use a lot of glucose and metabolize glucose the same way cancer cells do.
How about epilepsy? Anything with the epilepsy? Because my mom
Yeah.
actually has epilepsy too, but she doesn't have like shakes where she hits the ground, and she actually like it's like like a baby looks right through your eyes,
Yeah.
like when they're a
Yeah.
kid. Yeah, and you could be talking to her, and she'll just say random stuff. It's like she's not even there. You know
Yeah.
what I mean?
And
And
she's
then she comes
probably
back.
having what's called an absent seizure, where essentially she's having a minor seizure
Mhm.
temporarily and, still looks as though she's looking at you, but her attention
Yeah.
is
It
otherwise
doesn't
diverted.
making sense or whatever
Yes.
sometimes. Yeah, exactly.
So it turns out that the glucose map that we can do of the brain, and the brain is the area in the body that takes up the most glucose. It's doing the most metabolism of sugar because it's so incredibly active. And so in patients who are having an epileptic seizure, you may end up seeing an increase, a focus in their brain of where there's more metabolism. And so that area looks blacker on the
Mm,
image than a normal area of the brain. Patients who have a focus of epilepsy, an abnormality in their brain that's causing the epilepsy, we can sometimes see that as an area of decreased metabolism. This functional imaging, we're able to not only take a picture of the structures in the body, but we're able to look at utilization of glucose in the body, utilization of a variety of different types of metabolic processes, and create an image associated with it. So, the same way we can create an image of cancer, we can create an image of infection. We can create an image of the deposition of amyloid to look at Alzheimer's disease or amyloid cardiac disease. And for patients with epilepsy, we can look at not only the structure on an MRI scan, but the functional uptake associated with a variety of different causes of epilepsy. So, this functional
wow,
mapping that we're able to do with
insane.
the anti and we talked about the positrons being antimatter to electrons. And so being able to actually take antimatter and ship it around for medical purposes. And the half-life of the antimatter is about 110 minutes or so. So the logistics of being able to get these pharmaceuticals to the right place at the right time are a challenge, whether or not we're treating patients with radiopharmaceutical therapy or whether we're diagnosing them. The challenge that we have is that they have a shelf life, almost like
Mhm.
shipping something that's on ice, where the radioactivity, the effectiveness of the therapy or the diagnostic agent as it ends up decaying becomes less and less. So there's the delivery of this on time and the ability to
Wow.
be able to get it to patients quickly is really important. The logistics of delivering something to Chicago and New York are relatively easy, but the
Mhm.
logistics of getting something out to a rural area in the US and getting these things with a limited shelf life are really an interesting exercise in supply chain.
Yeah, so that's a challenge all in itself then.
Yeah,
Well,
absolutely.
so I wanna explain that to just to some people too, like, for me, I used to be in construction, so for concrete, it was the same thing. I just wanna so people can maybe understand. So
Of
for
course.
concrete, you only have a time limit on concrete when you can pour it in a wall or whatever you're doing, right? So
Mhm.
there's a time, and when I was working this is crazy. When I was working in Red Deer, Alberta, it was like -40, okay? I'm building a bridge and -40. It sucked. Every time you blink, your eyelashes stick together. Like, it sucks, okay? I don't. The money was great. Money was great, but that's it. So the plant was, I think, about an hour and 20 minutes out, but we were only allowed a 45-minute time. So the concrete was only allowed from the plant
Wow. Yeah.
45 minutes, and then it started. So they would have to stop and add like plasticizer or whatever it is in there to keep it so it's not hardening. But we sent back, we're pouring a bridge and we sent back 5 trucks because it's important, right? It's for the government's bridges
Yeah.
and stuff like that. But we had to set, so it's kind of like, I know, but is it kind of like that where
Oh
at the
no,
time?
exactly.
Yeah.
That's a fantastic analogy, actually. And
Okay.
the challenge we have is even though pharma can deliver the radiopharmaceutical that we need, even to the clinic, there's so many variables. I mean, traffic. Patients get
Yeah.
stuck in traffic. You have patients who are already sick, and maybe they're not able to get out of bed. Some of them
Yeah.
have, metastatic disease to their bones, and they have issues with mobility. One of the things that's really important is even though we still have this similar problem that you were describing with the concrete and very
Yeah.
limited timing where you have to orchestrate the timing just right, we're dealing with human beings. And so, the question is you've got, some of these radiopharmaceuticals that are incredibly expensive and, you know, you want to be able to give the patient the full therapy. You want to time it correctly. And even, helping patients figure out how to get in on time and, sometimes calling for,
Hmm.
an Uber or a Lyft for a patient, sometimes clearing the way with relatives. I mean, this whole thing is so human based and, so subject to all of the frailties and all of the challenges and the uncertainties and kind of the human factor. And so, it's one thing in construction, which is a huge challenge. And then the other one is how do you end up managing all of these things, coordinating all of these in
Hmm.
a world where you're dealing with scared, frail humans who are coming to you for treatment of their cancer. And
Hmm.
that becomes a significant challenge. And that's why what we do at United Theranostics is concentrate on this particular aspect of radiopharmaceuticals rather than being kind of you know, every different thing to every different patient that maybe a um, hospital might be or an ER
Hmm.
outpatient center, for example. So this is what we specialize in.
Can I ask you something?
Of course.
Going through all of this, and like as a doctor and like having these, I mean, sometimes you're gonna have really hard conversations with people. You know what I mean? You
Yeah,
really are, right? Especially in that field. Like, how does that take a toll on yourself, man? Because I know you're helping everybody, but I want to ask you,
sure.
like, are you okay? You know what I mean? Like, how do you take, like, how does that help you? Like, how do you be able to, like, what do you do for yourself? I want to make sure that you're okay because you're going out there and you're helping all these people. But what about you, man? You know what I
Yeah.
mean?
No, I really appreciate that. And it really does take a toll. For me, I've made a pivot in my career from being the guy, that you'd mentioned earlier that one of the things that I did early in my career was changing the paradigm. The entire
Hmm.
world was reading images on film. And because of my background in computer science and interest, actually jumped from film and created the world's first department where we actually used computers and monitors so that
Hmm.
everyone could look at the images, so that we could enhance the images, we could utilize AI for the images also. And so in my career, I've mainly been behind this computer monitor and view box interpreting scans and not dealing with patients directly. And so as I've made this pivot to theranostics, now I'm meeting with the patients,
Hmm.
I'm meeting with the families, and there are patients, I can remember one just recently where the patient had tried every different type of therapy. And the patient had qualified for a clinical trial that was a brand new type of theranostics using an alpha particle, which is 8,000 times more massive in treating and killing cancer cells than the beta particles that we've
Oh
been talking
wow.
about
Okay.
and are FDA cleared. And so, as the patient was just coming in for his treatment in this brand new, incredibly exciting thing that had given him hope, it turned out that his lab value, his platelet count, ended up being too low to be able to
Hmm.
qualify for the clinical trial. So it wasn't my decision anymore. I might have worked with him in partnership to say, well, you're at greater risk, but maybe we'll still consider the therapy because it could be a life changing thing for you.
Mhm.
But the clinical trial sponsors, because of the fact that they have to meet that scientific rigor and there are inclusion and exclusion criteria, this patient was no longer eligible. So
Eligible.
talking with him about the fact that what he saw as his last big hope, not being able to do that therapy and just, sort of talking that out with him, and seeing the disappointment that he had and not really being able to come up with another viable possibility that he had not tried, except to say, let's see what happens with your, platelets. Maybe they'll recover. Hopefully, I mean,
Mhm.
he was deteriorating fairly rapidly. It's hard to turn that off when
Mhm.
you come back home again and you're
Mhm.
thinking about the patients and thinking about the day. And, that the frustrating thing for me is very much like you, I really want to help people. I mean, that my career
Mhm.
has been dedicated.
So all I
The
wanna
things
do,
I'm
my
proudest
friend.
of are ways I've been able to help patients and also, been able to mentor so many, students and fellows and colleagues, et cetera. But having to face the limitations of what it is that we can't do, and my going back and going to AI and going on Google and trying to look at the literature and bringing his chart up again and thinking, what else is there? And so I think we're all vulnerable. I think in a lot of other professions, maybe you can kind of go home and you can
Mhm.
kind of, put it away. But, when people look to you and depend on you for their, safety and their life, that makes it really tough. And, you're in a profession where you really don't ever want to make a mistake. I mean, in most places,
Mhm.
if you're, you know, in manufacturing or, industry, et cetera, it maybe there's a certain acceptable
You got a
rate.
a a wiggle room usually
Yeah,
somewhat, yeah.
exactly. But
Yeah.
that's not always the case, with patients. So it really can take a toll on me. I mean, fortunately for me, most of my career, I have not been directly in that position with patients. I started out as kind of a surgeon doing something called interventional radiology. There, I would directly be able to interact with patients and see when I was doing something that relieved a patient's pain or relieved an obstruction. But then, there's always going to be the complication. In order to help patients, we also have to hurt the patients. And so
Mhm.
making an agonizing decision about whether we should treat a patient, realizing that, say, that their renal function or their platelets are compromised. And then do you make the decision, let's treat them because this is their best hope? Or do you not hurt them essentially, but by not further worsening their renal
Mhm.
function or their liver function or their marrow function? So making that decision, and, sometimes you might be on the side of the patient and say, let's go ahead and treat, even though it's kind of borderline. But, you know, having cases where you say, well, in retrospect, this patient really deteriorated. Maybe we should not have pushed that hard, or maybe we didn't push hard enough. And
Mhm.
there's no way to know. So I
Yeah.
really appreciate you asking, but that does take a toll on you as time goes
Mhm.
on. And of course, trying to then set up a national practice. I mean, anytime you try and a national business, whether it's a Chick-fil-A or whether or not, it's a medical practice, there are all sorts of questions about, well, how rapidly do you expand? We've
Well,
tried
there's
to
a
go
lot of all this, right? Like, you got the yin and yangs and everything, like,
exactly.
good always comes bad, right? Yin and yang, I say this all the time on my podcast.
Yeah.
Yin and yang, everything to life, there's a positive and there's a negative. Everything,
Yes. Yeah.
everything, what you do, there's a positive
Yeah.
and negative, right? And that, like, what you're saying is there's positives that come with it, but also there's negatives that come with it.
Yeah, and I think it takes a toll on practitioners. I mean, I think, one challenge for me is probably it'd be great to be able to get a little bit more sleep at night. It would be
Mhm.
great to have a little bit more time for me to be able to maybe do some of the doctor's appointments that maybe I've been putting off.
Mhm.
They say you're supposed to see a dermatologist once a year. It's been quite a few years. And there always seems to be something more important to do every day or worrying about the practice or the patients. And I think we tend to really not take care of ourselves
Mhm.
as much as we should. And so I think you're asking, questions about mental health and stress, and it certainly can take the toll. I think the way I balance that is I've got such a sense of curiosity and wonder in what we're doing and being a pioneer. I mean, whether it was creating the world's first filmless radiology department or doing new things with AI diagnosing images or being able to pioneer a practice that essentially is utilizing these information systems or being on the IBM Jeopardy team or, you
That's
know,
crazy. That's
advising.
crazy. I'm sorry.
Yeah, so all of those things and then having so many students, depend and look up to you for their careers and their guidance. So, it can certainly be a lot. And
Mhm.
the biggest challenge to me and many of my colleagues is just looking out for ourselves and figuring
Yeah.
out the balance. And how do you balance, family? My wife puts up with a huge amount of travel that I end up doing. And when I am going to see patients, sometimes I travel to cover for colleagues. I was at Princeton recently and I've covered other places, and that's time away from family also.
Mhm. Mhm.
So, yeah, so I really appreciate the question, and it, really can be a big challenge sometimes.
Yeah. And you gotta take time for yourself, really. It doesn't matter who you are, if you're the
Yeah,
president or you're the garbage man. It doesn't really matter. At the end of the day, you need to take time for yourself. And that's why I'm looking at all you guys too, is like, take time for yourself. Do something that, is gonna fill your own bucket, and keep, because life is hard. Life sucks. It does suck. It really does, at some points, but I mean, that's what makes it exciting. And if life was boring, then life would be boring. I mean, if it was normal, then life would be boring at the
yeah,
end of the day, you know?
yeah, and I think seeking out ways to be able to help people in
Mhm.
many ways is the best type of therapy.
Mhm. I agree. That's what I do, and
Yeah,
like after all, like I've had so much loss in my life, all the way up to like from
mhm,
age of 5. Plus I had PTSD from eating meat because I got in trouble and it messed my head up. So it's like 32. I've had so much problems, right? I wouldn't say problems. I would say more or less it gave me grit to where I am today, And would I change any of it? Hell no, man. It made me who I am today. I wouldn't be sitting here with you,
yes,
and having this conversation.
yeah,
So, and me giving back and helping people is just, it's what fills my bucket. And that's why I was happy to get away from construction too, because construction used to fill my bucket. I used to build houses, build high rises, give
mhm,
people homes,
mhm,
families, homes. It was a beautiful thing. But now I fell into this field, and like with the raw minds, men's mental health, and now I'm doing my AI 99 free build, and that's what really fills my bucket and it gives back. When I'm helping someone,
yeah,
I mean, there is no more joy unless like my daughter, obviously, but there's no real joy. Like, really helping someone and putting a smile or saving, like I've helped men, not take their lives, I've
yeah,
reached out and that alone, what I mean, has filled my bucket more times than I can account.
yeah, no, I understand and feel the same way. One of the things that I wanna mention is that although I am in a field that's incredibly high tech and do research and really appreciate the technology, really appreciate the innovation. So many of the patients who come to see us are also experiencing major mental health
Mhm.
challenges, experiencing loss, experiencing stress. It's amazing. We have I have a patient who has had 7 different types of cancer,
Wow.
that they end up suffering with. So, I think the challenge is how do you set the tech aside for just a moment and
Mhm.
interact and treat the patient in the same way, that you're doing the podcast and you have guests on where you're asking them to sort of tell you about what it is that is on their mind per se. It's
Mhm.
amazing how often when you spend the time talking with the patients, it's more than just the cancer that they
Mhm.
have. And in so many cases, it's the family or what's going to be the implication. I mean, they're worried about other people,
Mhm.
and many of them have really complex issues. And so taking the time to consider the patient holistically
Mhm.
and being able to get to know the patients and our practice is such that we don't have so many patients that we can't give individual time and get to know the patients. And it's one of the more gratifying things. And so realizing that whether or not a patient comes to you for cancer or addiction or whatever the specific thing is, that you need to understand the patient as a whole and to essentially interact and help them with that greater understanding.
Mhm.
And, part of it is interacting directly with the patient, but being able to have AI digest 500, 600 pages of information, including family history, and then kind of getting a briefing like your Helen briefing, essentially, or
Mhm.
overview from multiple systems allows us. So as we go into the computer era, ironically, it allows me to personalize and connect with my patients interpersonally using the computer as a tool, not as something that distances the patients from me.
Mhm. It brings you closer at the it brings you closer, yeah.
Exactly.
Yeah. I love that, man. I wanna say, like, we are getting to the end here, but I wanna say, like, what you are doing for this world is life-changing, and I hope you're proud, I hope you feel proud, I hope you're proud of what you're doing, and I'm proud of you and your team, I
Okay.
really am, and please let your team know that Raw Minds really stands behind you guys, and will stand behind. I'm very proud of what you guys are doing and changing lives. I really think
Hey,
it's very inspirational,
I
definitely.
really appreciate that. And if there's just one listener that you have that is inspired to get, whether it's their, transrectal, glove prostate exam, or their PSA, or somebody that has been told they have cancer but has not gone in to be able to have it treated. I mean, if there's only one patient, this was, by far, super worth it, and super gratifying. So I really appreciate the opportunity to be able to reach out to people that I might not have had the opportunity to do that. So thank you
I
so much.
You're very welcome. And actually, you kind of inspired me. I'm 42 years old. I'm getting up to that age, so I was like, oh man, I'm not gonna lie. I was like, fuck, I'm not really looking forward to this when I get a little bit, couple more years here. But I mean, it's important. We have to keep our health up. So I
Yeah.
will not be streaming that. That will not be its own podcast. So don't even think of it. Okay. So
But be your own advocate. Be active. In other
definitely,
words,
yeah.
don't wait. And not only, be your own advocate, but be your advocate for keeping yourself healthy. The
Hmm.
old paradigm in medicine has been wait until you get sick and let's figure out what we can do to address that. Rather than that, trying to figure out what can you do to prevent being sick in the first place, and taking more of an active role there really, I think, can make a huge difference in maintaining really high quality of life for as long as possible.
And eating healthy, I think, is a big, huge thing with
Absolutely.
that, right? Eating
Yeah.
healthy is huge into that,
Yeah.
right?
Eating
So,
healthy, getting sleep, getting exercise, all the stuff that your grandma may have told you
mhm,
turns out to be what is best. And so, just getting up in the morning and thinking about what can I do for my own health, whether it's physical or
mhm.
mental, and setting some time aside for you, whatever it is that you've becoming engrossed in, I think so important.
I need that. I honestly need that. I put myself second all the time here. Like ever since too, like I'm building the legacy method. I'd wake up at like 7 in the morning and then I'd work until like 4 in the morning and then
Yeah.
get like I've trained my body that I can run on 4 hours of sleep and that's perfect for me. But I've been doing that for years. So it's
Yeah.
weird. You know what I mean? It's weird, but I can maintain like that. But
Yeah,
that's what
I
it
want
but
you to
I
do me a favor, Eric, and that is I want you to try and see if you can up that to 5 or 6 and see if it makes any difference
I'm
in your.
already I started one of my own programs,
Yeah,
so it's in my program, so trust me, I'm already
yeah,
working through it. I need
yeah,
to work on the sleep for me is my biggest thing. Like
yeah,
that is my number one enemy would be sleep, to be honest, because I have ADHD, right? And how I
oh,
think of it is like I could be doing so much things. You know
yeah.
what I mean? I could be doing so much things. Why am I gonna sleep when I could be doing this, 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 and that?
Yeah.
And when I'm
What if
doing
I
things,
what if I
pardon me?
told you that 5-hour sleep, Eric can actually get more stuff done in his 19 hours than 4 hour of sleep Eric can get done in his 20 hours?
I believe you.
Prove that to you,
I
then
believe you. I
yeah.
believe you. Trust me. Like, well, don't
So
get me
find
wrong. Like
your
when
own
I was in
sweet spot.
construction, I
Yeah.
would go to sleep like around 9 o'clock, 10 o'clock at night, and then wake up at like 5 in the morning. I was even at one point in my life where I wake up at like 4 in the morning, go to the
Oh,
gym,
mhm.
come home, meditate, journal,
Yeah,
do all that, and then go to and shower and then go to work. And
yeah,
that was my life. But
yeah.
things happen, you know what I mean? I had a lot of big things happen in my life and it's a little bit
Mm,
different now, just a little bit. But I have my daughter now too full time. I have a 12-year
great.
old. You know what I mean? So
Yes.
things are a little bit more different, but I just got to work around it, right? And it's just
Yeah,
about learning how to work around it. And she's been with me for now just over 2 years, so
that's
it's
fantastic.
been, yeah, it's been amazing. She's my best friend. She's my best friend.
Yeah,
It's amazing. So,
that's great. Maybe you can turn around to some of the cool things that you've been doing and discovering lately too, because
oh yeah, right. I'm not cool enough. I'm not cool enough for her. Are you kidding me? I don't want to
I
hang
had
out
the
with that.
opportunity that your audience doesn't have to chat with you a little bit about some of the cool stuff that you're
Hmm.
doing, and so please do keep that up. And
I will
I'm
appreciate
gonna
it.
follow what you're doing and love to learn more as time goes on. So thanks so much.
Definitely, definitely, and I do want to say anything new coming up in the future, man. Please, like you are part of the Raw Minds family now. You and your team, just know that I would love for you guys to come on, tell us new things, anything anything that you want to talk about. I would love for you guys to, and it helps people. At the end of the day, that's what it does. Pay it forward and
Sounds
help
great.
people, right?
It
So I
was really fun
appreciate that.
talking with you. I really appreciate it.
Appreciate you. I just want
You-
to say thank you, everybody, too, and thank you, Dr. Elliot Scott. Or say, sorry, that was the wrong. That's the
Oh,
other.
yeah. Well, that's okay. There's lots of
Siegel, that's it. We
Elliot.
we have two. Sorry, I got a little. I was telling Dr. Siegel before I had another Elliot on before Dr. Elliot. We got it mixed up there, so I apologize. Anyways, we will see you guys next weekend. I appreciate it, and thank you, Dr. Siegel. I really appreciate everything. Thank you.
Take care.
Take it easy, guys. We'll see you guys later. Bye. Awesome. That was a great episode.